Assalamu alaikum wa rahmatullahi wa barakatuh. Let's discuss today the topic of palpitations. So we are on the way of discussing the cardinal manifestations of cardiovascular system. So today's topic is palpitation. So let's begin with the name of Allah. So what are palpitations basically? So palpitations are defined as an unpleasant awareness of one's own heartbeat. One unpleasant awareness of one's own heartbeat. Patient may describe them as thumping, pounding, flipping meaning turnover, fluttering sensation. So these things, no, thumping, pounding, flipping, fluttering, these are all descriptions. It is nothing but forceful heartbeat. Okay, forceful heartbeat, which the patient describes as thumping, pounding, flipping, fluttering, like that, or a perception of skipped, missing, or forceful beats. So these skipped, missing are nothing but missed beats. Okay, missed beats, skipped beats, or missed beats, or forceful beats. So they can describe like this. The sensation can be intermittent or sustained. It can be regular or irregular. So these things you should remember. It can be episodic, or it can be continuous, or it can be regular and irregular. So that's definition of palpitation. So what is the etiology of palpitation? Palpitation are an extremely common symptom. Causes are can be, most common is, number one is cardiac cause, second is psychiatric cause, okay, third one is unknown, fourth is miscellaneous cause. Cardiac causes, arrhythmias are the most common cause. Psychiatric causes, anxiety disorders. Okay, miscellaneous causes, thyroid disorder like thyroid toxicosis, anemia, fever, and drugs. Okay, and in 16% of cases the cause is unknown. So remember, causes as number one cardiac, number two is psychiatric, number three we remember as due to fever, anemia, or thyrotoxicosis, and drugs. And in 16% of cases, no cause is found. So what is the pathophysiological mechanism behind these palpitations? Number one is abnormal rhythm. So when the rhythm becomes abnormal, there is awareness of the heartbeat. So that's one thing. Example, atrial fibrillation and ventricular tachycardia. So rhythm is abnormal, that's why the patient gets aware. Number two is enhanced contractility. So increased force of contraction makes a normal rhythm more perceptible. Example, hyperdynamic states like anxiety, meaning psychiatric causes, anemia, okay, aortic regurgitation. So all these things will cause enhanced contractility. So that's why a normal heartbeat becomes more powerful and the patient perceives it. Number third is post extrasystolic potentiation. What is that? Key mechanism for the sensation of missed or forceful beats. A premature beat, either atrial or ventricular, results in a short diastolic filling time and a weak contraction. Okay, that is perceived as missed beat. Then the subsequent compensatory pause allows for a longer filling, leading to a stronger subsequent contraction that is felt as a thump or forceful beat. So this subsequent response is according to Starling's law. Starling's law. What that law states, we have learned in physiology. Some more stretching of the muscles of the heart, more powerful the contraction of the heart. Okay, so this is the most important mechanism where, so some premature beat, like maybe premature atrial contraction or premature PVC or PAC or PVC. So in PVC, what happens? There is some ventricular premature beat, VPC. So it will be like this, something. Okay, and it will be followed by a compensatory pause, like this, delayed pause. Then will be a normal beat. That normal beat will be stronger. Okay, so this is a premature VPC, ventricular beat, and this is the compensatory pause. Why this compensatory pause occurs? Because of refractory period of the heart. No, when there is refractory period, so new impulses cannot be generated. So the refractory period will be prolonged. So because of this compensatory, because of this premature beat, there will be refractory period. Then the next beat. So in this VPC, because of premature, the ventricles will underfill. There will be low blood. They will contract again. That beat will be perceived as missed beat or skipped beat. Then the subsequent beat, because of the compensatory pause, the ventricles will have more time for filling. So because of that, there is more stretching of ventricles. More stretching of ventricles will cause more contraction of the ventricular muscles, that will be felt as forceful beat or thump. So that's the mechanism that is known as post extrasystolic potentiation. Remember this. Now, clinical assessment and diagnosis. So how do you assess a patient? How do you proceed? How do you approach? Okay. So whenever a patient has a history of palpitation, so he will describe like that. So first of all, you rule out the red flags of palpitation. What are the red flag? Whether the palpitation is associated with syncope or pre-syncope. Whether there is any history of underlying structural heart disease, may it be coronary heart disease or cardiomyopathy. Whether there is a family history of sudden cardiac death. Okay. And the fourth one is whether the palpitations are induced by exercise. So these are the 4 red flags which warrant urgent investigations. Okay, which warrant urgent investigations. So number 1 is whether the palpitations are associated with syncope or pre-syncope. Whether there is a history of structural heart disease. Okay. Whether it can be coronary artery disease or cardiomyopathy. Okay. Now third one is whether there is a history of sudden cardiac death in the family, and the fourth one is whether the palpitations are induced by exercise induced palpitation. Exercise induced. So if these 4 are there, then these are the red flags. These require urgent investigation and referral of the patient. Okay. Now if these are not there, then you will proceed step by step. How do you proceed? The primary goal is to determine if the symptom is caused by a life-threatening arrhythmia and to correlate the symptom with a cardiac rhythm. So you will take history, physical examination, and proceed to investigations. So history is the cornerstone of diagnosis. A detailed history often provides a presumptive diagnosis. Key questions to ask in the history. What questions you will ask in the history? So very important. You ask the patient whether you ask the onset of symptoms, onset of offset. If the palpitations are sudden in onset, then that suggests supraventricular tachycardia or ventricular tachycardia. And if the palpitations are gradual in onset, then that suggests a sinus tachycardia. That means benign. Okay. This is very important. Based upon rate and rhythm, you will identify the type of arrhythmia. Okay. Rate and rhythm are very important. We will see in the coming slides. Okay. So how do you identify rate and rhythm? So at the time when the patient present it can be possible that the arrhythmia may have resolved. Okay. If the arrhythmia is present, by palpating the pulse and taking the ECG, you will make easily the diagnosis of the type of arrhythmia. But most of the times when the patient present, there will be no arrhythmia. So just say the patient to tap it out on the table. Tap it out on the table. So with that, you will get the get information about the rate and rhythm. Okay. If the patient is tapping fast, then it is a tachyarrhythmia. If he is tapping slow, then it is a bradyarrhythmia. If his tapping is regular like a drum, then it can be supraventricular tachycardia or ventricular tachycardia. If his tapping is irregular, okay, like a bag of worms. What that mean, bag of worms? Suppose there is a bag which is filled with worms, and somebody is putting his hand in the worms. The sensation what he gets now, that feeling. So irregular feeling, irregular. So times like this, he will type like this. Okay. So irregular, if it is there, then it can be atrial fibrillation. Okay. Or it can be some ectopic beats. So this is very simple and important thing which you say to the patient. Just tap it on the table. Next, you will ask the patient what is the duration and frequency of the episodes. How long do the duration episodes last and how frequent they are. And this is also very important. What are the associated symptoms? If whether the symptoms are associated with syncope and pre-syncope or lightheadedness, and if this is present, then it is a red flag. Whether the patient is the symptoms are associated with chest pain or dyspnea, that indicates ischemia or heart failure. Whether the symptoms, whether there is after the episode, whether there is polyuria, patient urinates more volume of urine after that episode, then that suggests that is a classical feature of supraventricular tachycardia due to atrial stretch and release of atrial natriuretic peptide. So what happens is, so when there is supraventricular tachycardia, so the atria are contracting and fast and strongly. So because of that, there is atrial stretch and there is release of ANP from the, particularly from the right atrium. Okay, atrial natriuretic peptide. So at this time, when there is SVT, there will be decreased supply of blood to the kidney. So at the time of episode, patient will not have this polyuria because of decreased supply to the blood supply to the kidney because the arrhythmia is there. But when the arrhythmia subsides, when the paroxysmal supraventricular tachycardia subsides, the blood flow to the kidney will become normal, but this atrial natriuretic peptide will persist in the blood. So because of that, there will be polyuria after the episode of palpitation. So you should ask specifically whether there is uh, polyuria after the episode. Okay, this is important. Okay, remember these three things: associated symptoms, whether there is associated syncope, pre-syncope, chest pain, breathlessness. Okay, chest pain, breathlessness, and associated polyuria. Polyuria is a feature of acidity. Okay, acidity is very common arrhythmia. Okay, now what is the context of presentation? Whether it is after exercise, that is a red flag. Due to stress, after stress, or after alcohol intake, or caffeine intake, or nicotine, or positional changes. Past medical history, any history of underlying structural heart disease, then this is a red flag. If there is a history of structural heart disease, this becomes red flag. Is a single most important risk factor for serious arrhythmias. The presence of the history of presence of structural heart disease, may it be coronary artery disease or cardiomyopathy, is a very important risk factor for serious arrhythmia. Remember, when there is a structural change in the heart muscles, then the rhythm will become altered. So whenever there is due to some reason, due to some volume overload or pressure overload or due to ischemia, whenever there is a change in the structure of the muscles, there is a high risk of arrhythmia because rhythm also changes. Change in the structure induces change in the rhythm. Now we have learnt how to take the history. In the history, you ask about the onset and offset, sudden onset or gradual onset. You ask, very important, tap on the table to the patient. Okay, and what is the duration and frequency of the episodes, and what are the associated symptoms with that? Whether there is a history of structural cardiac disease, whether the palpitations are due to exercise induced. Okay, whether there is a history of chest pain and breathlessness associated with that, whether there is history of associated syncope. So all these things you ask in history. Then in physical examination, when you examine a patient, he will come, most of the time there will be no arrhythmia. Often the examination is normal between the episodes. So what you do, you take the vital signs, you measure the BP, you measure the heart rate, you check the pulse of the patient. Okay, check the saturation of the patient. Okay, uh, do a cardiopulmonary examination for any murmur, presence of any murmur. Okay, and any heart failure signs. All these things you will take. So vital signs are these things, these four: BP, heart rate, pulse, and SpO2. Next, you will see the rhythm. If the patient presents with that arrhythmia, then you can see the rhythm. Okay, take the ECG at that time. Then this is the most important, as discussed in the history, presence of any structural heart disease. So how do you identify whether the patient has structural heart disease? Patient doesn't know that he has structural heart disease. So there are signs of structural heart disease. So if there is a murmur, then there is a structural heart disease. If there are signs of heart failure, like elevated JP crackles, then there is a structural heart disease. Signs of cardiomyopathy, for example, if there is right ventricular hypertrophy, then you will have that what do you call elevation. No, I'm not getting that word on my tongue. So when you press the precordium, that heel of the palm will be elevated. Okay, so signs of cardiomyopathy, signs of chest pain, signs of heart failure, signs of and murmur. If these are present, these indicate structural heart disease, and you need to urgently investigate the patient. So this is a flow chart. Next one, easy flow chart. Sorry, this is a flow chart. to approach a patient with palpitation. Is the heartbeat regular or not? If it is irregular, then the cause can be ectopic beats, VPCs or PVCs or PSCs, or atrial fibrillation. If the heartbeat are not regular, it is if the heartbeat is regular and that regular heartbeat is in episodic form, episodic pattern, episodic increased heart rate which is regular and is more than 120 per minute, then you consider supraventricular tachycardia. If there is polyuria, then SVT can be there. And number second is ventricular tachycardia you consider. If not, if there are no discrete attacks, it is continuous in nature. It is continuous in nature. Okay. And in the heartbeat is there are no discrete attacks of tachycardia. There are no discrete attacks of tachycardia. It is continuous in nature. Then it can be, then it is a good sign. It can be sinus tachycardia, or it can be high stroke volume because of anemia, psychiatric cause. It can be a psychiatric cause, anxiety, anemia, thyrotoxicosis, or it can be a valve disease also. That valve disease causes hypertrophy of the ventricles, and that is continuously felt. So this is a very simple flow chart. So discrete attacks, whether the attacks are discrete, and condition is the heart rate should be more than 120 per minute, or whether the attacks are regular or not. These are the two important points in this chart. Now moving to the second chart. Sorry for this inconvenience here. Now, if the beats are missed beats or forceful beats, then that means that is irregular. No, that is irregular. That can be premature atrial contractions or premature ventricular contractions. Sudden onset offset, that means the beats are irregular, discrete in nature. Now, when they are discrete, if they are rapid and regular, in discrete, rapid and regular, that can be paroxysmal SVT or VT. If they are rapid and regular, and okay, they'll be discrete. And if they are rapid and irregular, then it can be atrial fibrillation, paroxysmal atrial fibrillation. It is not persistent. Remember, there is classification of atrial fibrillation. No, paroxysmal atrial fibrillation and persistent atrial fibrillation, and one more prolonged atrial fibrillation. Three classifications are there. So this is paroxysmal atrial fibrillation. Paroxysmal. Okay. So this will be in discrete, sudden onset and offset, and discrete attacks. Okay. Now, if it is gradual onset and offset, okay, gradual onset and offset, gradual onset and offset, again you will divide it as rapid and regular, that is sinus tachycardia due to anxiety or hyperdynamic state like anemia, okay, fever, pregnancy. Or if there is forceful heart at rest, then again it can be due to anxiety states, hyperdynamic states. Okay, and now this is episodic and this is at rest, or it can be due to aortic regurgitation also. So these are the two charts which will help. So sudden onset and offset, fast and regular, SVT and VT. Sudden onset and offset, fast and irregular, atrial fibrillation. Gradual onset and offset, fast and regular, then it is due to hyperdynamic circulation. Gradual onset and offset, but forceful palpitations at rest, then it is hyperdynamic circulation, including aortic regurgitation. Okay. So remember only one thing: if it is gradual onset and offset, no discrete, gradual onset and offset, then it is a benign cause. Sudden onset or offset, discrete attacks, as we have in the previous table, no, flow chart, then it can be SVT or VT. This is one point. Remember, a variable intensity of the first heart sound, S1, variable intensity of the first heart sound is suggestive of AV dissociation, as seen in ventricular tachycardia. So what are the investigations you will do? So number one is dual lead resting ECG, whether the patient has or not the palpitation episode. You should do this ECG to the patient because it may show evidence of structural heart disease. What are those evidences? Prior MI, Q waves, you can see Q waves. Okay, left ventricular hypertrophy. Okay, bundle branch block. All these suggest a structural heart disease: bundle branch block, LBBB, RBBB, or bifascicular block also. Bifascicular block. So LBB is always abnormal. RBBB, most of the time it is seen in normal patient also, and bifascicular block, and LVH and PRMI. So all these things will indicate some structural heart disease in a patient with tachycardia, or some predisposing condition like pre-excitation, WPW syndrome. In patient with WPW syndrome, what you will have a slurred upslope of the QRS complex like this. In WPW syndrome, you will have this is Q like this. This is T wave, P wave, and slurred upslope. P wave and slurred upslope. So this slurred upsloping of R wave is seen in WPW syndrome. That's how you identify. Okay. Long QT syndrome. So QT interval will be prolonged. Brugada pattern in V1, V2, V3. The ST segment will be elevated. So these predisposing conditions, WPW syndrome or long QT syndrome, Brugada syndrome, these are also predisposed to arrhythmias. Okay. So that's how an ECG can help in identifying structural heart disease or some predisposing condition which can cause a serious arrhythmia. Now, other investigations which you can do are ambulatory ECG monitoring. So there are either it can be 24 to 48 hour Holter monitor, or it can be event recorder, or it can be loop recorder. So this is done when there is daily or near daily symptoms. Okay, it depends on the frequency. Event recorder is patient himself activate when he will experience the episode. So this is done when the symptoms are less frequent, weekly or monthly like that. Patient transmits rhythm strip via phone when symptoms occur. Newer devices include smartphone linked ECG recorders. A loop recorder. What is loop recorder? It can be external or implanted loop recorder, implantable loop recorder. So external is 1 up to 2 weeks, constantly records and overrides data, saving the loop when the patient activates it. New versions are small waterproof patches. Injectable device for very infrequent episodes, like for every few months. Okay, records automatically and can be interrogated remotely. Gold standard for diagnosing. This is a gold standard for diagnosing infrequent syncope and palpitation. Implantable loop recorder, gold standard for diagnosing infrequent syncope and palpitations. 24 to 40 hour Holter monitor for daily or near daily symptoms. Event recorder, patient recorded, and loop recorder for infrequent. This is for frequent, this is for infrequent. It can be external or it can be implantable. Next investigation is echocardiography. This is not routine for all patients, and it is indicated when you are suspecting some structural heart disease by history, physical examination, and ECG. Or when there is a high burden of ectopy. VPs are so much. For example, some book says more than 8 to 10 VPCs. If you see, or if the VPCs are polymorphic, not one morphology they have more than one morphology. So polymorphic VPCs or more than 8 to 10 VPCs, that is a high burden of ectopy, then those patients should be evaluated for structural heart disease. A high risk of serious arrhythmia or history of sudden cardiac death, so in the family, that also requires echocardiography. So these are the 3 conditions where you go for echocardiography when you are suspecting structural heart disease. Okay, when you are suspecting structural heart disease, when there is a high burden of ectopy, third is when there is a history of sudden cardiac death. What are the simple laboratory tests you will do? CBC will do for anemia, thyroid function test, electrolytes. Which electrolytes? Magnesium, calcium, and potassium. Serum metanephrin when you suspect pheochromocytoma. Patient will have paroxysmal rise in BP. This is the history, no? Serum metanephrin. So most commonly, anemia you will check for, and thyroid function test you will check for, and electrolytes you will check for. These are the most common. CBC and means full blood count, and thyroid function test, and serum potassium, calcium, and magnesium. Baseline blood test for in a patients with palpitation. So now what is the one more is there, electrophysiological studies. So this is an invasive test, and it is used when there is to define the mechanism of a documented tachyarrhythmia, and it can also be used for curative catheter ablation. Now, what treatment you will give for this patient? Treatment. The treatment part. So the treatment is number one, reassurance and lifestyle modification for benign causes like for hyperdynamic circulation, sinus tachycardia, gradually occurring, gradual onset and offset, rapid and regular. That indicates some benign cause. Discrete attacks indicate some life-threatening cause like SVT and VT. Okay, and if it is irregular, that is also some that can be VPCs or atrial fibrillation. Okay. So it is reassurance and lifestyle modification in benign causes like sinus tachycardia, benign ectopies. Benign ectopies, remember, ectopies are not benign if they are polymorphic or more than 8 to 10. Anxiety, psychiatric cause. Advice to patient to avoid triggers like caffeine, alcohol, stimulants, stress. Provide reassurance to the patient. Once serious causes are excluded, patient should be told the prognosis is excellent. So when you will give reassurance and lifestyle modification? So when the serious causes are excluded, then you will give this one. Now, if the patient still has symptoms despite reassurance lifestyle modification, beta blockers you can give for symptomatic relief in benign ectopy and anxiety driven palpitations. Now, if there is specific arrhythmia, specific antiarrhythmic therapy is based on the diagnosed arrhythmia, rate control for AF, and ablation for supraventricular tachycardia. SVT is mainly due to the abnormal pathway which runs from the atria to the ventricles. Okay, so ablation of that pathway, catheter ablation for supraventricular tachycardia and rate control for atrial fibrillation. That is about the pharmacotherapy. And next thing is driving restrictions. So must counsel the patients on driving regulations as per UK and DVLA guidelines. Bans are often required for certain symptoms like syncope and arrhythmias until they are controlled. So when they are controlled, you can give, but the patient is still under investigations. First, you control the symptoms. When the patient is stable, then you can give the license. So this is about the topic of palpitations. Thank you for your listening. We will meet in the next video.